Okay, so COPD. Please feel free to pause anytime. So, most people don't know why it's even called an obstructive lung disease, but that should pretty much explain it. And then this is just a division of what COPD is, emphysema, and chronic bronchitis. And if you've done or you're doing a residency or something along those lines, then you're probably going to get something called this MKSAP, Knowledge Self-Assessment Program, and it seems like a great book. I'm still not at residency yet, so you should get it. According to the Medical Knowledge Self-Assessment Program, it says that inflammation in COPD, it damages and thickens the small airways, therefore disrupting the normal repair mechanism of the lungs and the small airways that undergo fibrosis. So because of all of this, there's going to be proteases that are released, right? Proteases, they dissolve some of the adjacent supporting lung tissue that tethers the small airways. Therefore, there's going to be a decrease in the elastic recoil of the lung that normally keeps the airway open during expiration. Therefore, there's a decreased elasticity of the lung parenchyma, and that is called static hyperinflation. PD, the important one is dynamic hyperinflation, which by definition is a phenomenon that occurs when a new breath begins before the lung has reached the static equilibrium volume. Okay, so they are called as pink puffers in emphysema because they have a hyperinflated emphysematous barrel-shaped chest due to air trapping, whereas in chronic bronchitis, they're called as blue bloaters because they exhibit more signs of polycythemia and cyanosis. In emphysema, one of the theories is that there's an alpha-1 antitrypsin deficiency, ZZ genotype, which should be suspected in patients who are less than 40 years of age. Alpha-1 antitrypsin is an enzyme which normally, if in a normal person, inactivates the neutrophil elastase, preventing the destruction of the lung parenchyma. However, when mutated, it allows the neutrophil elastase to destroy the lung parenchyma. The biggest culprit, however, in COPD is going to be cigarette smoke, hands down. So the connecting airways are surrounded by smooth muscle which contains adrenergic and cholinergic receptors. So stimulation of these by the circulating catecholamines of the beta-2 adrenergic receptors causes dilatation of the airways. Whereas irritant stimuli may cause bronchospasm or constriction of the airways via the vagus nerve. Hence, hyperactivity or bronchospasm to noxious stimuli may contribute as a pathogenesis mechanism. So one of the things that is seen as a late state in patients with COPD is a tripod position is when they sit forwards on their hands, possibly knees, to support themselves with the pursed lips breathing. That's so they can better use their accessory muscles of respiration to help them breathe better. The Gold Class classification of COPD defines the airflow obstruction as a post-bronchodilator FEV1 by FVC ratio less than 70%. MMRC is purely a clinical diagnosis based on symptoms and even signs. The Bode classification is a composite disease marker that takes into account the systemic nature of COPD. A Bode index score of more than or equal to 7 is equal to 4-year survival rate of less than or equal to 20%.